Okay, continuing off from part one of our lecture, let's continue on with our sympathomimetics. Next is epinephrine. Epinephrine is an endogenous catecholamine that stimulates all of the receptor sites, alpha, beta 1, and beta 2. It can be administered IV, which means it can also be administered IO, but also IM and subcutaneously. Although in cardiovascular administrations, it's always given either IV or IO. It can be given intratracheally, but we've already talked about the fact that that route is now of questionable value. And it can also be nebulized, and again, that's in the form of racemic epinephrine. It can dramatically increase cardiac workload and myocardial oxygen demand, but it's also thought to increase peripheral perfusion and, importantly, cerebral perfusion in patients who are suffering cardiac arrest. Although that's at this time, being very much questioned as to whether or not it truly has those effects, those beneficial effects for patients in cardiac arrest. Moving on, two more drugs in this sympathomimetic, and remember the sympathetic nervous system is the fight or flight system of the autonomic nervous system, is dopamine with a brand name of Entropin. It's the primary medication that's given for hypotension that doesn't respond to volume resuscitation. You must make sure that your patient is has an adequate volume resuscitation in the presence of hypotension before dopamine is administered. And dopamine, again, is an endogenous catecholamine, whereas dobutamine is synthetic, but it's similar to dopamine and quite frankly isn't routinely used in the pre-hospital setting. You may have a transfer patient that might be on dobutamine. And again, we'll have more details as we go. Vasopressin is a potent vasopressor, makes sense based on its name. It can treat GI bleeding, diabetes insipidus, shock, and cardiac arrest. Vasopressin is used as a substitute for epinephrine in some cardiac arrest protocols, although its routine utilization has been called into question in the new emergency cardiovascular care guidelines. We'll get more into that later on. We have direct vasodilator medications. There's one primary one we'll talk about, but these are used in the management of things like uncontrolled hypertension, congestive heart failure, myocardial infarction, cardiac ischemia, and cardiogenic shock. The primary one that we think of is nitroglycerin in the field. It dilates veins and coronary arteries. The interesting thing is it doesn't differentiate between the two, so it can lower blood pressure. The primary reason why we use it is to try to relieve chest pain, to dilate coronary arteries so that blood flow might return to areas where it's been either cut off or greatly restricted. We can also use it to decrease blood pressure, but its use in decreasing blood pressure solely to decrease blood pressure and not in the presence of chest pain is pretty rare now in pre-hospital care. I'll look up its incidence here later on as we talk about the particular drugs as we continue through the course. We generally don't give nitroglycerin directly IV. We usually give it sublingually. And we're going to switch over here to more of the issues for us administering it sublingually. Again, I've never seen nitroglycerin that's being given IV by paramedics in the field. If we do provide nitroglycerin, it is usually sublingually, either through a tablet or a spray. And remember that giving multiple doses quickly is prone to cause tolerance. The body becomes used to having particular levels in the system and it doesn't work as well. The tablets are prone to degradation, and that's the reason why you may have seen people carrying a very small bottle of very small tablets of nitroglycerin in a very dark colored glass bottle. Exposure to sunlight makes this medication ineffective. Also, we have to be aware, and this isn't such a big deal now, but it was when the erectile dysfunction medications first came out. Giving nitroglycerin to these folks is relatively contraindicated. Either your protocols will say it should not be given in the presence of Viagra or Cialis, or it'll say that you must call medical control if you still believe that it's necessary. Diuretics. Diuretics cause urination, and these can be administered to correct volume overload, to manage CHF, which is kind of a form of volume overload. Improve respiration in pulmonary edema patients. And again, CHF patients often call us because they're having difficulty breathing because of pulmonary edema. And in a background for us, it's also potentially can preserve kidney function, but that's not really one of the primary reasons why a paramedic's going to give this in pre-hospital care. One of the primary diuretic medications is furosemide, also known as Lasix. Again, we'll learn dosages and things like that later on, but we do have to watch out that we don't give diuretics to someone with hemodynamic instability, primarily hypotension or trending towards hypotension. We have to watch out for that. And the administration of Lasix has kind of taken a back seat of late. Especially with the advent of continuous positive airway pressure administration in the field. We seem to be able to do a pretty good job at keeping CHF patients going through CPAP and letting the folks at the hospital with more resources and abilities provide for the diuresis of the patient. Another diuretic medication, and it is available on Kentucky's formulary, is mannitol, which can be given to decrease intracranial pressure that's associated with cerebral edema and head injuries. It's also a drug that's used in blood transfusion reactions, and frankly, I'm going to have to read up more on that. But blood transfusion reactions oftentimes cause what looks like an allergic reaction that can include the activation of a histamine response, which will cause fluid to build up in areas where it shouldn't be, and mannitol can help out with that. Our next major area is blood product administration. Now, I will tell you that I have never provided a blood product. The problem with blood is that it requires refrigeration. Almost all blood products do. There are a few that don't, but really not something that we're going to be giving as paramedics, except in highly specialized situations. So we'll go through this quickly. Blood components should be type specific, cross-matched, or unmatched. They should be typed and cross-matched. If a choice is not clear, we should contact online medical control or the sending physician. In other words, we might have a patient with blood hanging on a transfer, but hopefully they will have received the blood over long enough time that we know whether or not there's going to be some sort of reaction to that particular product. That'll be something to discuss with the sending physician or a nurse there from the sending facility. Blood products require careful monitoring of the pulse rate and blood pressure. We need to reassess temperature frequently. One of the first signs that a person's having an adverse reaction to blood product administration is that they'll suddenly have an increase in their body temperature. And if there is a urinary catheter present, we need to monitor for changes in urine color. In the presence of a serious blood reaction, the urine will quite suddenly start to become dark, almost to the point that it's the color of cola, like a Coca-Cola or a Pepsi-Cola drink. And that's the sign of a very serious systemic reaction to the blood product. We'll talk more about that later on in the course. The administration to correct anemia, and then of course in pre-hospital care, anemia is usually because red blood cells are leaking out of the body through a hole somewhere. The rate of administration should be proportional to the rate of blood cell loss. And again, that's not something we can measure. So we don't usually give packed red blood cells or RBCs. These are concentrated red blood cells where most of the volume of the blood has been removed and the red blood cells in the hematocrit is what's been left behind. Each unit carries about a quarter of a liter. Sorry, I went ahead there. Again, you have to give this with an IV of normal saline simultaneously. And you'll see here, typically administered over no longer than 4 hours per unit. While you may give it relatively rapidly, again, this doesn't lend itself to emergency use in the pre-hospital environment. Units usually contain some sort of citrate-based preservative, and this can cause some electrolyte imbalances. Again, read in your book for more details. Another blood product that's out there that you might see is fresh frozen plasma, also known as FFP. And this can be used to treat impaired blood clotting. Now, this you might see in a hypovolemic patient being transferred from an outlying hospital to a trauma center. This has to be compatible with blood type, but it doesn't need to be Rh compatible. Read in your book more about that. I happen to be O positive. But I could, number one, I could receive even O negative blood. Negative can go into a positive person, but positive blood can't go into a negative person. But the nice thing about fresh frozen plasma is that it doesn't need to be Rh compatible. So all it has to be is blood typed, AOB or AB. But they also require defrosting. This stuff usually, well, obviously comes frozen and it requires defrosting before it can be placed into a patient. There is the risk of what's called a cryoprecipitate, which is a blood product that contains a concentrated assortment of clotting factors without the additional volume present in an FFP. So in other words, they remove particular blood clotting factors and just place those into the patient. Sorry, this isn't a complication. This is more of a different type of product. Check, check, check. Platelets can be separated from whole blood and then placed directly into patients. This can be used to correct thrombocytopenia, but they must be blood typed and Rh compatible. Please read in your book more about the administration of platelets to patients with thrombocytopenia. I won't get into that in great detail here. We won't be concerned with that. There are medications that we can give that can alter blood performance, such as blood platelets combining to form blood clots. Or that blood platelets combining to form blood clots. There are different types. There's actually a newer drug out there called TXA, and we'll get more into that. It's tranexamic acid. And you'll excuse me if I'm not pronouncing that quite right. But there's actually, most of the time in emergency care, we're interested in making sure that clots don't form on the inside of the body. But now we are actually beginning to see a drug that may form clots that can help people stop bleeding internally and even externally if we can't find the source of the bleeding. But normally we think more in terms of anticoagulant therapy. Heparin and Lovenox. These impair clotting functions, and you may see patients that are on either one of these two drugs chronically. Another one is Pradaxa that is given to patients in atrial fibrillation, and we'll understand why that is later on in our course. Next are antiplatelet medications, which make the platelets not stick together as efficiently. The one that's big for us is aspirin. And now Guidelines 2015 says that any person who is experiencing chest pain should chew 326 milligrams of aspirin and swallow. And that is now a recommendation that's given even to dispatchers and to the general public. Drugs that are also given, and aspirin is also given chronically, daily 82 milligram aspirin. Clopidogrel, Plavix, and this other one here that I'm just going to say the brand name, Ticlid, are other drugs that you may see patients on. If you see these on a medication list, you know that they have something that the physician, their personal physician, wants them to not create thrombi for some reason, and thrombi is the plural of thrombus. Fibrinolytics are used to dissolve blood clots. So once a blood clot actually is formed, fibrinolytics can come by and actually cause those to fall apart. Here we're talking about TPA, which you may have seen in emergency rooms or have heard of through the journals. TPA is a fibrinolytic, whereas aspirin is an antiplatelet. Aspirin by itself won't break up a clot. A fibrinolytic will. Next, we're going to move on here to medications used for neurologic conditions. They're treating pain as a neurologic condition. And if it were me, I would just say medications used for pain. Any medication that's used for pain is called an analgesic. Depending on how they work, some stimulate opioid receptors to relieve pain. They are known to cause tolerance, cross-tolerance, and addiction, and also can provide for profound sedation, respiratory depression, and even apnea if you give too much or give it too quickly. The two big ones that we know in pre-hospital care, especially, the first one here is morphine. But know that morphine is known to cause nausea and vomiting in up to 28% of patients. So it's almost always given with some antiemetic. We'll talk about those here in a little bit. Next is fentanyl. The nice thing about fentanyl is it doesn't have that risk of nausea. Remember, we don't want our patients vomiting in the field because that gives us a potential airway threat. Now, on the flip side of our narcotic analgesic medications, is our opiate antagonist, and that's naloxone or Narcan. Efficacy can be dose dependent, and we should only administer enough to correct a life-threatening condition. So the bottom line is we administer Narcan to the point that they become conscious and able to hold their own airway. Because remember, those narcotic overdose folks aren't dying so much from directly the narcotic overdose. They're dying from the fact that the narcotic overdose makes them stop breathing. So we need to only give enough so that we get them to start breathing on their own again, hopefully. Another, again, I've not thought of this as an opiate antagonist. Dilantin is an anti-seizure medication. I'm almost wondering if there's a typo here in your book. I'm sorry, I haven't had time to redo the slides. I'll correct this in class for you. Dilantin and phosphonatoin is, and again, I'm terrible at the drug pronunciations, so somebody else will give you a different pronunciation of that one there. These are drugs that are generally given on a long-term basis. I have not seen these used. For pre-hospital care. I'm looking over our formulary list for our course, and Dilantin's in the book, but not listed on national or Kentucky lists. And again, phosphonatoin is also not listed on Kentucky or national, but is in your book. Dilantin and Cerebrex are given to prevent additional seizures or seizures over a long term. We generally give medications only when a seizure is in progress to attempt to stop the seizure temporarily, quite frankly, usually temporarily. And then once we get to the hospital, they will provide a medication such as this to keep another seizure from occurring. Histamine 2 receptor antagonists. These are drugs affecting the GI system. Again, these are Zantac, Tagamet, Pepcid. These are not going to be given to by us, paramedics, in emergency situations. Interestingly enough, Tagamet, once an allergic reaction or an anaphylaxis arrives to the hospital, Tagamet is a medication that I've seen used for the long-term management of patients with anaphylactic reactions to get them over the anaphylaxis. We use Benadryl and epinephrine. Epinephrine is fast acting and short acting. Benadryl is a little longer acting, and then the Tagamet hopefully will get them through to the point that whatever is causing the reaction ceases or is metabolized. Antiemetics are used to treat nausea and vomiting. With the 28% of people who get who become nauseated or begin to vomit with the administration of morphine, oftentimes morphine and Phenergan are given together. But Phenergan has some fairly powerful CNS depressant problems. So you give that in combination with the morphine, and you may actually cause even more pronounced respiratory depression. So it's something that has to be monitored very closely. But morphine and Phenergan used to be a standard order in emergency rooms, not so much in EMS. There's also a new medication out there called Zofran, and we'll talk about that in class. Its brand name is Zofran, and all of a sudden I can't remember the generics, and I'm not going to give you a wrong one. Okay, calcium preparations and miscellaneous medications. These can be used for an antidote to calcium channel blocker overdose, treatment of magnesium toxicity, magnesium sulfate. They can be used for the prevention of dysrhythmia. Haven't seen most of these. They go beyond what it is we can do in pre-hospital care. We just don't have the resources to be able to perform these sorts of these procedures. We're all alone out there. One of the things that it is used for quite often is it's an antidote in a surface preparation or through the skin preparation for calcium restoration from hydrofluoric acid exposure. We'll talk more about that later on. And the drug that's used for that is calcium gluconate, and it's actually in a gel that can be placed on the skin. Watch out that if you have a patient who has a calcium preparation of some sort and you're on a transfer, need to monitor those IV sites. Calcium can cause redness and swelling at IV sites and eventually infiltration, where the medication actually goes up underneath the skin instead of in the vein. So just watch your IV sites closely if you have a calcium preparation. Next is dextrose. Generally in adults, we give a 25-gram dosage of a 50% solution. So we give 25 grams in 50 mLs. Need to try to give this through a large bore IV if we can. It can be a little bit, it's kind of acidic, so it can hurt a bit. So we want to make sure that we give that through a large bore catheter. Diphenhydramine is Benadryl. It's given in a variety of clinical situations, but the one that we provide it for the most is for its competitive antihistamine. Competitive histamine 1 receptor antagonist. It's for allergic reactions. Quite frankly, just as it is in the over-the-counter oral administration as well. Glucagon is given deep intramuscular injection. It's used to treat hypoglycemia, especially in patients where we can't get an IV. What it causes is the liver to begin to produce sugar. And that's called glycogenesis. We'll talk more about that later on. It's also used to treat severe beta and calcium channel blocker overdoses. Again, we'll talk more about that. Next one is Ketorolac, and that's commercially known as Toradol. It's a non-steroidal anti-inflammatory drug, a good analgesic, and we'll talk again more about that in the specific lectures. Magnesium sulfate is an electrolyte medication in cardiac arrest, in particular kinds of cardiac dysrhythmias. This is provided primarily. We'll talk about what those are, but they're ventricular dysrhythmias. Also, it can be used to relax smooth muscle tissues, and this is used in women who are in preterm labor to stop premature contractions. Again, I haven't seen that in pre-hospital care for the contractions, but magnesium sulfate is also given to pregnant women who are having seizures secondary to the word escapes me, but seizures related to eclampsia. There it is. Finally, it was at the top of our list. It was one of the ones, well, it was the alkalinization agent at the top of our list of the chart, sodium bicarbonate. Generally given rapid IV or sometimes in IV fluids. It depends on what you're giving it for. Its use as a cardiac arrest medication is highly questioned now and is now considered to be not appropriate for routine use in cardiac arrest. But it's also used in situations where there are EKG changes, especially indicated in the presence of a tricyclic antidepressant overdose. And again, we will talk about those in great detail when we go to each one of the drugs. Our last drug is thiamine. It's a commercial medication that is a preparation of vitamin B1. And it is often given to persons who have questionable nutritional standards when they are hypoglycemic. Thiamine assists in the metabolization of sugars. So this was part 2. Thank you so much for your attention, and have a good day.